As I told you, acid-base balance ko lagi, there are 3 lines of defense in our body. First line is buffer, second is very good, third is renal. Temporary solution is the buffer one because it is limited capacity. The strongest the buffer system which comes into play is always the renal. So our buffer, when we are talking, you know what are the different types of buffer: intracellular, extracellular buffer, right? Which is the most important buffer in our body? Bicarbonate buffer. Now you will be asked in your viva, why is bicarbonate buffer considered to be the most important buffer system in the body? You need to have why. The answer key, what? Why is bicarbonate buffer the most important buffer system in the body? Okay, it is number one, present in larger amount. Also, the percentage wise, it's the largest buffer that is present. And the next one is, if you look at the buffer, Henderson-Hasselbalch equation, if you look at that, if you see, what do you see? Kun organ, let's say, they are handling that buffer pair. Bicarbonate buffer, like kun organ they handle garirasa? Lungs and kidney, right? Because lungs, whenever the carbonic acid, bicarbonate is more, then what will happen? When the acid is more, the bicarbonate buffer will combine with the acid to form carbonic acid, and ultimately that excess acid is exhaled out as carbon dioxide, right? And the lung will have different mechanism to maintain the acid-base balance. So you know this much. Buffer ko yahi boy. Intracellular, extracellular. Extracellular buffer, what are they? What are the extracellular buffer? Protein buffer, and you have the bicarbonate buffer. And coming to intracellular buffer, again protein buffer is also in the intracellular space, and orkukun buffer huncha the phosphate buffer is the intracellular ma predominant huncha. Now protein buffer ma again we have different types of buffer: hemoglobin buffer, yes; amino acid buffer, yes; and one more, and plasma protein buffer. Because albuminहरुमा पनि histidine हुन्छ नि, because histidine has an imidazole ring which has the capacity to take the acid proton here and there. Bujho? So we talked about the buffer. Now coming to the respiratory system. How does the respiratory system it maintains the blood pH? By hyper and hypoventilation. And what are the mechanism which comes into play? That is, they have a peripheral receptor, pH chemoreceptor, and central chemoreceptor. So peripheral center ma, depending upon the extent of acid-base balance, the respiratory system will come into play by hyper and hypoventilation. Now coming to the renal mechanism, how many mechanisms are, you might be asked in your question, as your theory question or in viva. What are the 4 mechanisms by which the kidney helps to maintain the acid-base balance in the body? So you have 4 mechanisms. Start from number 1. Chart a mechanism with a suitable diagram. Now this is a question that I'm giving you. If Isma, you have to draw the diagram, explain the mechanism with each diagram. So kiki mechanisms are, if you studied in your theory, what are the 4 mechanisms? Number 1 is, very good, exchange of hydrogen ion with the help of sodium hydrogen exchanger, right? NaH exchanger. Sorry. Next is reclamation of the bicarbonate, right? Reabsorption of the. Third is titratable acid. So titratable acid ma ki hune bhayo? What comes as titratable acid? Sodium dihydrogen phosphate ko rupma. And next is excretion of ammonium ion. When ammonia huncha ni kidney ma, there is an enzyme known as glutaminase. Jasle chai glutamate lai it breaks down to glutamine, right? And then and ammonia. त्यो अमोनियामा चाहिँ एउटा अर्को H plus excess acid भएको केसमा चाहिँ एउटा one more H plus can combine with that ammonia and it will form what? Ammonium ion. Okay, and the ammonium is excreted. So these are the 4 mechanisms. So now let's come to report interpretation. How do we approach a report? How do we approach acid-base disturbance? Whenever you see a report, acid-base report, ABG report, first thing that you have to know is whether it is acidemia or alkalemia. So paila, to identify whether it is acidemia or alkalemia, what is the parameter that you see? pH. Very good. Now, after you see that, Number 2, is acid-base disorder metabolic or whether it is respiratory? And third step, now if you interpret the report to be as metabolic acidosis, if you are looking at the report, if it is a metabolic acidosis, you have to calculate the anion gap, because metabolic acidosis there is either a high anion gap metabolic acidosis or a normal anion gap metabolic acidosis, and there are list of conditions which will lead to high anion gap metabolic acidosis, and there is a mnemonics to it, mud piles. So high anion gap metabolic acidosis भयो भने जहिले पनि MUDPILES भन्ने एउटा mnemonics छ. मड पाइल्स भनेको मिथेनॉल टॉक्सिसिटी हो कि यूरेमिक सिंड्रोम हो कि, डी भनेको डायबिटिक कीटोएसिडोसिस, P is I think paracetamol poisoning या पैराल्डिहाइड टॉक्सिसिटी, PI isoniazid, I भनेको isoniazid थेरेपीमा पनि you see high anion gap metabolic acidosis. PIL, L is lactic acidosis, LES is I think salicylate, let me check. S को के हो? Salicylic acid, right? So what was the third step? Second, you categorized it as whether it is respiratory or metabolic. If it is metabolic, you calculate the anion gap to diagnose it as high anion gap or normal anion gap. If you calculate anion gap, calculate गर्दाखेरि, we will see कसरी anion gap calculate गर्ने, त्यो सबै it will come. So if you think it is an anion gap, high anion gap metabolic acidosis or alkalosis, what you have to do? You have to think of the conditions as in mud piles. Okay, and there is another condition which will lead to normal anion gap metabolic acidosis, which we will come in some time. So if it is metabolic alkalosis, a metabolic acidosis, you have to check for anion gap to categorize it as. Now if it is metabolic alkalosis, then you need to categorize it as chloride sensitive versus chloride resistant metabolic alkalosis. Now coming to respiratory acid-base disorder, you have to, based on the reports, you have to see whether it is acute versus chronic. And there are conditions where there is mixed acid-base disturbances. Okay. Now having said this, whether this acid-base disorder, the ABG interpretation, you diagnose the patient to have metabolic acidosis based on the report, but you also need to check whether there is compensation or not. Kinaki renal ma kehi problem bhayo bhane the respiratory system always tries to compensate, and whenever there is problem with the respiratory system, the renal will compensate. Okay, it's always reciprocated that way. So you need to know that. So compensation chha ki chaina. So these are the approach to interpret the acid-base reports. Whenever we diagnose a condition to be metabolic acidosis, the metabolic acidosis is always due to the decrease in the bicarbonate. Okay, the main reason for metabolic भन्नुको मतलब के हो त? Bicarbonate is decrease. When I say respiratory acidosis, what is the main thing in the picture? pH is acidosis, but the main parameter that you check next and then say that this is respiratory acidosis is what do you check for? PCO2. And what does PCO2 happens in case of respiratory acidosis? Okay, carbonic acid, we cannot measure carbonic acid. Carbonic acid, we are measuring carbon dioxide, right? So what happens to carbon dioxide in case of respiratory acidosis? Okay, so PCO2 increases. In case of metabolic acidosis, pH decreases. pH is less than 7.35 along with bicarbonate decrease. We are not looking at the PCO2 compensation ko lagi ta PCO2 you have to check. We are not doing that. We are just saying it is metabolic. pH decrease with PCO2 increase. We call it as respiratory acidosis. Is it clear, boy? Now, when we say metabolic alkalosis, we say due to what will happen in metabolic alkalosis? Bona? pH will increase. Next, most important, very good, bicarbonate is also increased. Next, respiratory alkalosis. Now, what will happen to PCO2 now? Decrease. So, see, overall, if there is increased addition of acid, decreased elimination of acid or increased loss of base, यो तीनटा कन्डिसनमा के हुने भयो? एसिडोसिस हुने भयो. बेस अल्कलोसिस केमा हुने भयो? increased addition of base, right? Decreased elimination of base, yes or no? अर्को increased loss of acid. Now decrease in the bicarbonate के कारणले हुन सक्छ त? एउटा त loss of bicarbonate, yes or no? So loss of bicarbonate के condition मा हुन्छ त? When there is loss of your duodenal fluid, right? Loss of duodenal fluid भनेको के हुन्छ त? What are the condition where there is loss of duodenal? Very good, diarrhea, right? एउटा diarrhea, एउटा kidney is not able to reabsorb the bicarbonate. Very good. So decrease tubular reclamation of the bicarbonate. This is one cause for, what did we say? Increase in the acid also will lead to metabolic acidosis. Okay, now why does increase in the acid leads to metabolic acidosis? Is because whenever body मा चाहिँ acid को level बढ्यो, जस्तै lactic acidosis भयो suppose हैन, endogenously नै कुनै condition ले चाहिँ acids हरु चाहिँ increase भयो भने your body will use that bicarbonate to compensate that acid, to neutralize that acid. जसको कारणले bicarbonate is decreased, and that is leading to metabolic acidosis. Now coming to, as I told you, high anion gap or normal anion gap. हैन, high anion gap मा, as I told you, mud piles. Go and look at the mnemonic. मैले अलिअलि त भने methanol poisoning यो भनेर, तर normal anion gap मा चाहिँ जस्तै कि तिम्रो चाहिँ loss of bicarbonate rich fluid from the kidney or proximal convoluted tubule, जस्तै diarrhea हरुमा चाहिँ के हुन्छ त? You have a normal anion gap metabolic acidosis. Clear up till here? Okay. What is anion gap? Anion gap, it is defined as the difference between the total concentration of the measured cations and that of the measured anion. So total positive charge that you can measure minus total negative charge that you are able to measure. So the unmeasured part, like जुन तिमीले measure गर्न सक्दैन, त्यसलाई चाहिँ we call it as the gap that you are measuring, and that is known as anion gap. ठीक छ यति? So the formula to calculate the anion gap is sodium plus potassium in one big bracket, that is cation, minus chloride plus bicarbonate. Normal range of anion gap comes as 8 to 18 milliequivalent per liter. Kunai book ma you will see 10 to 14. Kunai book ma you will see 10 to 16, but the average is 8 to 18 is your like your range, and the average is 12 milliequivalent per liter. ठीक है anion gap. Now if you have a report, ABG report like this, first thing, if you think it is metabolic acidosis, right, you will look at the pH, you will look at the bicarbonate. Bicarbonate घट्ना साथ र pH low छ भने it is always metabolic. But the next thing that you calculate from here is you will calculate the anion gap. So sodium पनि यही हुन्छ ABG मै, potassium पनि यही हुन्छ, sodium plus potassium minus big bracket मा chloride plus bicarbonate. So you calculated the anion gap also now, right? Now once you do that, what you need to understand is, like, you saw the pH low, right? Next thing you did is you saw the bicarbonate low, and you also checked the PCO2. A pH low हुँदाखेरि यदि respiratory cause हो, respiratory, if that is respiratory acidosis in presence of pH low, then what would happen to the PCO2 level? It should have been increased, right? But if you see that PCO2 is normal, if you see PCO2 is normal and bicarbonate is low, it is metabolic. Yes? Now you want to see whether there is compensation. Metabolic ma kale compensation. Who is going to compensate? Respiratory. How does it compensate? By hyperventilation. Because it is acidosis, your body wants to excrete out more acid, right? So body le kun form ma acid la excrete out गर्छ त, carbonic acid la, in form of carbon dioxide. So body, your respiratory centers will be triggered, peripheral center system will be triggered, and you will be hyperventilating. ठीक छ? So once you are hyperventilating, what will happen to your carbon dioxide level? If I'm breathing out fast, that means I'm exhaling those acid outside. Yes? So what will happen to my PCO2 level when I'm breathing more carbon dioxide outside? My PCO2 level is decreased, right? So if my body is compensating for that metabolic acidosis, my PCO2 level should decrease. Ideally, PCO2 level चाहिँ यदि respiratory cause हो भने increase हुनु पर्थ्यो, but since it is metabolic, number one, bicarbonate is decreased, and since my body is trying to compensate the increase in the acid production, it hyperventilates. So hyperventilation will lead to what? it will lead to decrease in your PCO2. Let's connect the dot. pH is decreased, PCO2 is normal, and then bicarbonate is decreased. You calculated the anion gap, okay, it is normal, suppose. So how will you write the diagnosis? Normal anion gap, metabolic acidosis without respiratory compensation. Because why am I saying without? Because PCO2 normal thing. अब यही चीज सेम डिट्टो बट PCO2 is decreased, normal भन्दा कम छ. So 35 to 40 is normal, my PCO2 is 20. So what will I assume? बडीमा चाहिँ compensation भइरहेछ, because the compensation को कारणले hyperventilation भइरहेछ, it is happening that way. So if you look at the PCO2, then how will you be making the diagnosis? Normal anion gap, metabolic acidosis with respiratory compensation. Compensation छैन भने जस्तै pH decreased, right? अब मेटाबोलिकमा के भयो, एरो बनाऊ. pH is decreased, bicarbonate is decreased down. If PCO2 is normal like this, then it is non-compensated. But if PCO2 is also down, means if all the three arrows are in the same direction downward, then metabolic acidosis with compensation. So diarrhea is one of the most important cause for your metabolic acidosis, okay? And you do not or renal tubular loss of bicarbonate due to any kidney, like glomerular filtration problem भयो, your renal failure patient you might see, because bicarbonate retain गर्न नसकेर, you might see a normal anion gap, respiratory metabolic acidosis. Clear on this part? Okay, now coming to metabolic alkalosis. Okay, now it occurs when, what did I say? Base is added, acid is lost more, base elimination is decreased, or acid rich fluid, but say the acid is lost. So what is the most common cause? If I think general, very good. Vomiting हुँदाखेरि के हुन्छ? Your gastric juice are acidic in pH. So if you are vomiting, के हुन्छ? All the acid fluid are taken out from the body, right? So in that case, acid loss को कारणले चाहिँ the condition is known as base comparatively the base is increased because of your acid loss, so that condition will lead to your metabolic alkalosis. What will be the ABG report? What is the ABG picture of these things? So what will happen to the pH? First thing that you will look at is your pH. So what will happen to the pH? Increase more than 7.45. pH is increased. Now next thing, to call it as bicarbonate, I mean metabolic, you have to look for bicarbonate. So what will happen to your bicarbonate level? Increases. So if there is a compensation, if there is no respiratory compensation, PCO2 is normal. But if there is no compensation, what will it happen? Respiratory system ma PCO2 चाहिँ के हुन्छ? Increase हुन्छ. त्यसको लागि बडीले कुन, what is the mechanism that your body? Hypoventilation. So respiratory center लाई चाहिँ depress गरेर it makes you breathe slowly and leads to hypoventilation, जसको कारणले चाहिँ your PCO2 level बढेर चाहिँ बडीमा चाहिँ एउटा acid को level is maintained in the body. All right, see it's going in the same direction. pH increase, bicarbonate increase, and PCO2 is also increased if it is a compensatory mechanism. Clear? Okay. अब kidney पनि it plays role by how does the kidney tries to compensate? Kidney but suppose for example vomiting को कारणले you have what? Your metabolic alkalosis, right? So what does kidney do? Kidney will decrease the sodium hydrogen exchange. It does not want to now exchange the hydrogen because it wants to retain that hydrogen to balance that bicarbonate. The sodium hydrogen exchanger, which was supposed to excrete out your H plus, now the H plus the more acid is being lost. So what does the kidney do? It responds by decreasing the sodium hydrogen exchange. It decreases the formation of ammonium ion because ammonium H plus was used, and it will also decrease the reclamation of bicarbonate. Now it does not want to already alkalosis, so your charoda mechanism, it's always playing in that line. Now coming to respiratory acidosis. Now how do you look at the respiratory acidosis? Now what in case of respiratory acidosis, what will be your pH? Decrease. what will happen to your partial pressure of carbon dioxide? Increase. So yaniri, when it is respiratory, it is going in the opposite direction now. Now, what are the most common cause which will lead to your PCO2 to be raised? Any condition which will depress your respiratory system. जसको कारणले चाहिँ breathing is hypoventilation को case. Hypoventilation भयो भने what will happen? PCO2 will be increased because you are not able to excrete that carbon dioxide out. So what are the conditions which leads to hypoventilation? Now you have to think in that line. Just like COPD, chronic obstructive pulmonary disease. Your lungs are constricted, the patient is not able to breathe properly. Bronchitis, pneumonia, right? And any drugs like morphine or anything which will depress your central nervous system, the respiratory center in your central nervous system. So drugs like morphine and all, because it will depress the CNS respiratory center, it will lead to hypoventilation and it will lead to respiratory acidosis. So now in case of respiratory acidosis, how will the compensation happen? Bicarbonate level should increase. So for compensation, it is increased. For non-compensation, the bicarbonate level is normal. Respiratory acidosis, so it wants to excrete out acid. So sodium hydrogen exchange, what will it do? It will increase. It will increase the sodium hydrogen exchange. It will increase the ammonium formation. It will increase the now reclamation of the bicarbonate and thus increase the bicarbonate level. So renal compensation, however, is not effective initially. So it comes into play only after 6 to 12 hours. And it is not optimal for until 2 to 3 days. Now coming to respiratory alkalosis. What are the condition again? pH increase, okay? Huh? PCO2 will decrease. Very good. PCO2 will decrease and pH will increase. Now, can you tell me what will happen to bicarbonate level if it is compensated or not? Compensation boy, when you bicarbonate in respiratory alkalosis, it decreases. Hyperventilation will lead to respiratory alkalosis. Got it? Okay, so hyperventilation only condition or any drugs that will stimulate your respiratory system, CNS disorder, mechanical hyperventilation, and salicylate poisoning, paracetamol poisoning. Acute phase there is respiratory alkalosis, and chronic phase because salicylic acid is an acid, so chronic phase it will lead to metabolic acidosis. So to answer the acid-base status, first check the pH. 7.35 to 7.45. So acidosis or alkalosis you will see. And based on that, CO2 bicarbonate status you will see to categorize it as metabolic or respiratory. Now, third step, you will check whether the compensation is appropriate or not. So you will check the direction based on your thing. And the fourth is you will calculate the anion gap, and then whether it is acute or chronic, you can figure out that. Let's take for metabolic. What did we say? pH is decreased, bicarbonate is decreased, we call it metabolic. And if PCO2 is also decreased, we call it as compensation. Or PCO2 normal, we call it non-compensated. So what if PCO2 body rasa? भनेको त्यो पेशेन्टमा चाहिँ मेटाबोलिक एसिडोसिस हुनला डायबिटिक कीटोएसिडोसिस पनि छ एट द सेम टाइम सीएनएस को डिजीजले गर्दा चाहिँ उसको रेस्पिरेटरी सिस्टम पनि डिप्रेस छ सो ही इज नॉट एबल टु ब्रीथ प्रॉपर्ली सो त्यसले गर्दा त PCO2 पनि बढ्ने भयो सो दुईटा कन्डिसन छ त्यो पेशेन्टमा सो इट इज लीडिङ टु अ मिक्स्ड एसिड बेस पिक्चर metabolic so if your brain says the report is metabolic based on your pH and bicarbonate you have to calculate anion gap no doubt then you classify it as high anion gap report just if I give you this ABG in your OSPE and then tell you to interpret this report and if somehow you say this is metabolic acidosis अब आउँछ anion gap calculate गर्ने सम्म compensation भन्ने सम्म will you be able to give that proper diagnosis? Metabolic acidosis with respiratory compensation. High anion gap metabolic acidosis with respiratory compensation. Without respiratory compensation. This is how you give the complete diagnosis. ABG report. I am giving you a case scenario. Now, case number 1 is a 23-year-old man was found to be apneic and unresponsive in surgery ward following reconstructive knee surgery. Now, based on this, first tell me what is the thing that you noticed here first? You get a report. What is the first thing that you see? pH. Don't go to bicarbonate. Bicarbonate is okay, 23. So first thing that you see is pH. What is the pH here? So it is decreased, matlab it is acidemia or alkalemia. You know the difference between acidemia and acidosis? Acidosis is a state which leads to acidemia. Alkalosis is a state which will lead to alkalemia. Now this is first acidemia. So next thing, what do you do? To acidosis match, like bicarbonate acidosis explain garcha. If bicarbonate level decrease walk away, it would have correlated with your low pH. But here bicarbonate is normal, so you don't have to think of metabolic line. Now to see that acidemia, whether it is led by the partial pressure of carbon dioxide, you see what is 35 to 40, sir? So what is here? So kina PCO2 body rasa body ma? Why does PCO2 increase in the body? When you are not able to breathe, when there is hypoventilation, when there is depressed central nervous system, respiratory center. So here apneic morphine will depress your central nervous system. So what is this cause? It is acute or chronic now? Because turunta 30 minutes ko history sa. So it is acute respiratory acidosis without metabolic compensation. A 4-week-old baby boy is admitted to hospital with history of projectile vomiting of several day duration. Projectile vomiting, vomiting is something triggered in your mind. What is the thing that is triggered? When you are vomiting, gastric juice is what? Acidic. So a lot of vomiting is there. The pH is 7.5. Take so PCO2 is 49 and bicarbonate is 37. Everyone done with that? Okay, so what was the diagnosis? First, tell me whether it is acidosis or alkalosis. Huh? Alkalosis. Whether it is metabolic or respiratory. And then is it compensated or non-compensated? It is very good, partially compensated because PCO2 level is just started to rise. Up to 45 हो full compensation मा के हुन्थ्यो त high एकदम 80 90 मा पुग्थ्यो. तर because it just started compensating, it's just the beginning phase, it is partially compensated. Okay, now if I have to give you a proper diagnosis for this, it is metabolic alkalosis from persistent vomiting due to probably pyloric stenosis with partial respiratory compensation. Now coming to case number 3. Okay, so a 26-year-old woman is undergoing treatment for frequent panic attack. Okay, so panic attack means our first thing when you imagine a person with panic attack, what do you think that person is doing? Breathing fast. So you already got the picture what case is going to come, right? What case might come? Because the person is breathing very fast, hyperventilation, exhaling out more carbon dioxide. What is the most probable case that we are dealing with? Respiratory. Breathing out more carbon dioxide means you are letting that out and your body carbon dioxide level is decreased. So that is hyperventilation will lead to acidosis ki alkalosis. Because I'm throwing out, I'm exhaling more acid out, my body my acid को level ki huncha, what will happen to the so it will lead to alkalosis. So don't get confused. Getting it? So already you got a picture from the history that the patient is treated for frequent panic attack accompanied by hyperventilation, tachycardia, dizziness. In one severe attack, when taken to emergency, an ABG sample was taken and the blood pH was, ABG report was pH 7.52, yes, PCO2 26, and bicarbonate 22. So, interpret the report. So what did you make the diagnosis? Respiratory alkalosis without metabolic compensation. Yes, because bicarbonate is normal and you are calling it respiratory because first thing it is alkalosis. Yes, pH is high. Second is to correlate that pH, the PCO2 is low. Yes, so it is a respiratory cause. Got it? So the diagnosis would be here acute respiratory alkalosis from hyperventilation due to panic attack. Another case here, a 31-year-old man presents with lethargy, weakness, labored respiration, confusion. He is diabetes for 15 years. He has diabetes for 15 years, suffering from intestinal flu, avoiding food to help further vomiting. He thought that it would be a good idea to stop the insulin, and when seen in the emergency department, his urine dipped positive for both glucose and ketone bodies, and his breath had a strange, sweet, fruity smell. Okay, so the following were the ABG report. Now, based on the history, ke dimag mein aaye, diabetes patients are, and then now, when we say diabetic ketoacidosis, normally, if you remember the mnemonic mud piles, what is the type of acidosis that you see in mud piles? Huh? The matra metabolic acidosis. High anion gap metabolic acidosis. So let's look at this case now. Now, pH is 7.27. Write it down. PCO2 is 23 mmHg. Sodium is 132 milliequivalent per liter. Chloride is 83 milliequivalent per liter. Sodium is 132 milliequivalent per liter. Chloride is 83 milliequivalent per liter. Potassium is 4.9 milliequivalent per liter. Bicarbonate is 10 milliequivalent per liter. Glucose is 345. So now interpret all the reports, whatever you have to do from this case. Yes. Huh? Yes. pH is 7.27. Now calculate whatever you can from this, make your diagnosis, and then we will discuss. First, you need to diagnose if it is metabolic acidosis or not. So you, based on that two report, you thought that you identified it as metabolic acidosis. Now, once metabolic acidosis is, you think of that. Now, whether it is compensated or not, it is respiratory compensation. Why? Because the patient is hyperventilating, so breathing out more carbon dioxide out, so the PCO2 level is decreased. And it is also given in the history that the patient has a positive fruity smell in the breath, right? Okay, and then the third thing is, okay, then you said it is compensated metabolic acidosis. Now you have to see whether it is anion gap you have to calculate. So how much was the anion gap? Kati calculate garyo? Kati? So it is high anion gap metabolic acidosis, okay, with respiratory compensation. Quick one. 22-year-old man was severely injured in the chest from motor vehicle accident. So large flail rib segment in his thorax is compromising his breathing. A blood gas sample was taken revealing pH 7.21. Now let's be very quick. Eh? pH 7 accident was a chest compression, ribs fracture. pH 7.21, PCO2 65, bicarbonate is 25. The quick one, come very quick with the answer. ABG, your mother data, you don't have history, means you cannot know whether it is acute or chronic. But if history is given, you can, respiratory, you can always add that word. So it is acute respiratory acidosis without metabolic compensation from hypoventilation secondary to pleural chest injury. Now next one, okay. 44-year-old man, moderately dehydrated, was admitted with 2 days history of acute severe diarrhea. Diarrhea, Vanasat, what should be coming? Loss of bicarbonate. Normally in diarrhea, there is normal anion gap metabolic acidosis. Based on the clinical findings and all, you can think with the history itself, right? So diarrhea, Electrolyte sodium, potassium, chloride, bicarbonate is given. So pH 7.31, PCO2 33 mmHg, bicarbonate is 16, PCO2 is already told. So sodium is 134, potassium is 2.9, chloride is 108, and bicarbonate is 16. Now interpret the report and tell me. So it is, and what is the anion gap? Calculation of the anion gap? Huh? So it is normal. So how do we make the diagnosis? Normal anion. Tell me. Metabolic with 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 adequate compensation. 7.35 to 7. Almost it is 7.31. No? So it is adequate compensation, adequate respiratory compensation, most likely secondary to severe diarrhea. Right? Now, so there is a last case over here. A 70-year-old man with a history of congestive heart failure presents with increased shortness of breath and leg swelling. ABG 7.24, PCO2 60, HCO3 27. Now come up with this diagnosis. PCO2. So you see, what is it first? It is acidosis. It is because PCO2 is increased. It is respiratory acidosis. It is acute respiratory acidosis, and it is likely secondary to here because he has congestive heart failure, shortness of breath, edema. So it is most likely due to pulmonary edema on us. So thank you everyone. I hope the topic was clear. Now you can see this and interpret it by yourself. Right? Okay. Thank you.